This is now our discussion on pediatric genitourinary disorders. Normally, the urinary system maintains the proper balance of fluid and electrolytes in the blood. As a brief review, the kidneys, particularly the nephrons, they filter blood, they secrete waste products, and reabsorbs fluids, electrolytes, nutrients, and other essential particles until urine is formed. The ureters, on the other hand, are where urine travels down the body. The bladder stores urine, and the urethra, which is different in structure among boys and girls, expels urine. When disease occurs, such as with structural abnormalities or kidney malfunction, children may be left with excessive amounts of fluid in the body or with an imbalance of electrolytes essential to their body's functioning. Usually, the disorders involving the kidneys and urinary tract often are long-term. To help in assessing the functioning of the urinary system, the following tests can be done. One is urinalysis. It's the most simple test of kidney function. Please read and review the average urine output for children in 24 hours and the characteristics of urine as well. These are in tables 46.1 and 46.2 in your book. Specimens collected should be fresh because urine that is standing long at room temperature may change its composition. Second is the creatinine clearance rate. Glomerular filtration rate is the rate at which substances are filtered from the blood to the urine. It is measured by the amount of creatinine. It's the breakdown product of muscle contraction. It is excreted in 24 hours as determined by a 24-hour urine sample. Also, a venous blood sample is taken during that 24-hour period and compared it with the urine findings. If urine creatinine is decreased, venous sample will be increased. Normal clearance creatinine rate or normal creatinine clearance rate is 100 ml per minute. The normal urine creatinine is 0.7 to 1.5 milligrams per deciliter of blood, while creatinine in the blood rarely exceeds 1 milligram per deciliter. Third is urine culture. This detects presence of bacteria in urine, as in urinary tract infection, for example. This will specifically determine the pathogen so that proper antibiotics can be given. Fourth is a blood urea nitrogen test, or the BUN. This measures the level of urea in the blood and is used to assess glomerular function, or how well the kidneys can clear this from the blood. Normal value is 5 to 20 milligrams per deciliter of blood. Fifth are several tests. These are several tests: ultrasound, MRI, X-ray, CT scan. All these can visualize the kidneys, the ureter, or the bladder. Sixth is cystoscopy. This is the examination of the bladder and ureter openings by direct examination with the cystoscope. It's the equipment. It is introduced through the urethra. It is done to evaluate structures of both the bladder and ureter. A radio-opaque dye may be introduced so these structures can be visualized on radiography or on those mentioned in number 5. This is actually a painful procedure, so a child may be under conscious sedation, and after the procedure, the first voiding may be painful too, similar with other tests involving these invasive procedures. So, once allowed, urge children to drink plenty of fluids so they urinate frequently and flush out any pathogens introduced at the time of the procedure. Kidney function is necessary for life as it cleans our blood. If it deteriorates, some method to replace its function must be instituted. So in cases of renal failure, dialysis is important. Dialysis is the separation and removal of solutes from body fluid by diffusion through a semi-permeable membrane. You will further discuss this in your medical surgical nursing in your higher years, and here we will just give you a brief background. Figure 46.4 shows peritoneal dialysis. It uses the membrane of the peritoneal cavity as the artificial kidneys to cleanse blood. Second, figure 46.5 is hemodialysis. An external machine is used as an outside synthetic membrane. These are the different genitourinary disorders that we will discuss, so let us have them one by one. Hypospadias is a urethral defect in which the urethral opening is not at the end of the penis, but on the ventral or lower aspect of it. It is shown in figure A. Epispadias, on the other hand, is a similar defect in which the opening is on the dorsal surface of the penis, shown in figure B. Among the two, hypospadias is fairly common. It occurs in approximately 1 in 300 male newborns. It may also be familial or may occur from a multifactorial genetic focus. All male newborns must be inspected at birth for hypospadias or epispadias. This should be a part of routine physical exam. First, there is abnormal location of urinary meatus. The degree may be minimal, just near the glands, or maximal, midway or way far from the normal opening near the abdomen or scrotum. Second is core D. Many newborns with hypospadias have an accompanying core D. It's a fibrous band that causes the penis to curve downward. Third is cryptorchidism. Undescended testes is also often found in conjunction with hypospadias. And fourth, if the condition is severe, sometimes sex of the child is undetermined. If the penis defect is so extensive, sex may be unclear and might need sex cell karyotyping. If with minimal defects, some children need no intervention. But if surgery is intended, children should not be circumcised yet, because the surgeon may wish to use a portion of the foreskin during repair. First, the surgical procedure is called meatotomy in newborn, in which the urethra is extended to a normal position. When the child is then older, at about 1 to 1.5 years old, an adherent core D may be released if it is present. But if the repair is extensive, all surgery may be delayed until 3 to 4 years old. Urinary tract infection is the bacterial invasion, usually E. coli, that enters the urinary tract, most often as an ascending infection from the perineum. Because it involves the urinary tract, it may be called sometimes urethritis if in urethra, cystitis in the bladder, ureteritis if ureter, or pyelonephritis in kidneys. But all in all, it can be termed as UTI. This needs vigorous treatment in children so they do not spread to involve the kidneys, which is pyelonephritis. It may damage kidney function. It is common in children and girls. It is at a rate of 2 to 8% among girls. They tend to occur most often in girls than in boys because the urethra is shorter in girls and it is located close to the vagina and anus. Assessment findings: typical symptoms: pain or burning on urination, urinary frequency, or hematuria, but sometimes these may not be present. With cystitis, there may be low-grade fever, mild abdominal pain, or enuresis. It is also difficult to pinpoint that it's UTI. With pyelonephritis, high fever, abdominal pain, flank pain, vomiting, or malaise. In this case, symptoms are more acute. Diagnosis is through the above findings plus possibly urinalysis or a urine culture. Management: administer antibiotics. It could be given orally, but the antibiotic must be specific to the causative organism that was cultured in the urine culture. Remind parents also to finish the full prescription so infection will not return. Force fluids. These will flush the infection out of the urinary tract. Cranberry juice acidifies urine and makes it more resistant to bacterial growth. Third, you can provide the child with warm baths. Children may void into a tub of warm water, especially if there is painful urination. Fourth is giving mild analgesics such as acetaminophen if needed. Tylenol, for example, may decrease pain and allow easy voiding. Fifth is encourage perineal hygiene. This is for comfort and can prevent further infection or reinfection. Vesicoureteral reflux refers to retrograde flow or backflow of urine from the bladder into the ureters. This reflux occurs because the valve that guards the entrance from the bladder to the ureter is defective. In the photo, you will see that regurgitation of urine from bladder to ureter occurs because of the valve defect. This reflux leads to bladder infection because urine is retained in the ureters after voiding. This is what we want to prevent with vesicoureteral reflux. The stasis of fluid is subject to any kind of infection. This backflow occurs or happens during micturition or voiding when the bladder contracts, and this stasis favors the growth of E. coli. Assessment findings: it is first seen with history of repeated UTIs because as you treat the UTI, the child will be healed. But the presence of the valve defect will just cause re-UTI, so there is recurrent infection. A CT scan or cystoscopy can show the ureteral reflux. Management: majority resolve with maturity without the need for surgery. But until this growth occurs, teach children about double voiding and possibly the need for prophylactic antibiotic. When you say double voiding, it is having the child void and then after a few minutes attempt to void again. This will help empty the bladder fully and prevent recurrent infection from urinary stasis. Prophylactic antibiotic, on the other hand, will prevent bladder infection. If the condition is mild, long-term antibiotics may be as effective as surgery. This is to reduce renal scarring from recurrent UTIs. That is what we always want to prevent, renal scarring that will cause more damage to the kidneys. This is only for those with a lower grade of reflux, not for severe cases. If continuous antibiotic therapy does not prevent recurrent UTIs, reflux can be now corrected with therapy plus injection of deflux to stabilize the uterus. Deflux is a dextramer hyaluronic acid which will stabilize the ureter valves. And last, this is also the last resort, laparoscopic surgery to correct placement of ureters. This involves reinserting the ureters at a more oblique angle, which will create the normal valve effect. Hydronephrosis is the enlargement of the kidney pelvis. This is because urine has accumulated there because of back pressure in the ureter. Usual cause is an obstruction. The same with that of vesicoureteral reflux. Therefore, if vesicoureteral reflux is untreated, it can cause hydronephrosis. As seen in the photo, hydronephrosis leads to increased intrarenal pressure, causing decreased circulation to the kidney, especially the nephrons, and eventually may end up with atrophy of the kidney as seen in the last photo. Assessment findings: repeated UTIs, irritability, children cry when they void, elevated blood pressure because of the activation of the RAA mechanism. Renin is a hormone produced by the kidneys. Flank or abdominal pain. Abdominal palpation would reveal an abdominal mass. That's the dilated kidney pelvis. And in the ultrasound, it will show the enlarged pelvis and the point of obstruction. Treatment is surgical correction of the obstruction before kidney destruction occurs. This will prevent renal failure, which may warrant the need for dialysis. Glomerulonephritis is the inflammation of the glomeruli of the kidney. It occurs as an immune complex disease from an antigen-antibody reaction after infection with group A beta hemolytic streptococci. If you can recall, rheumatic fever is another condition which is caused by a previous streptococcal infection. The antigen-antibody reaction, in this case, causes a cascade of proteins which plug or obstruct the glomeruli, and this leads to tissue damage. Also, IgG antibodies against streptococci are detected in the bloodstream. This is a proof that the illness follows a streptococcal infection. It's common in boys 5 to 10 years old. There are also two other types of glomerulonephritis. It's the chronic glomerulonephritis and the IgA glomerulonephritis. But here we will only confine our discussion to acute post-streptococcal glomerulonephritis. Assessment findings. Again, there's a recent pharyngitis, tonsillitis, otitis media, or impetigo within 7 to 14 days or up to 3 weeks. These are caused by streptococcus. Ideally, children should have urinalysis 2 weeks after the infection to evaluate that glomerulonephritis is not occurring. Second, there's a sudden onset of hematuria and proteinuria. Urinary sediments also contain WBCs, epithelial cells, and RBCs. Hematuria here is so gross that urine would appear tea-colored, reddish-brown, or smoky. In proteinuria, there's a 1 plus to 4 plus protein. While on a 24-hour urine specimen, protein is about 1 gram. Normally, urine contains none. Blood analysis will also show low protein or hypoalbuminemia. Third, after these initial urine changes, the child then develops oliguria. Specific gravity elevates because of this. This would also mean fluid retention, hypervolemia, and then leading to edema. Fourth, due to this hypervolemia, hypertension then occurs. If blood pressure is so high it reaches 160/100, the child is at risk for encephalopathy. Encephalopathy may be shown with signs of headache, irritability, seizures, vomiting, or decreasing level of consciousness. So we have to watch out for that. Fifth, there is edema, abdominal pain, low-grade fever, anorexia, vomiting, or headache. This is a result of the continuous inflammatory reaction. Sixth, the excessive plasma fluid may also lead to cardiac involvement with signs of orthopnea, cardiac enlargement, enlarged liver, pulmonary edema, and the galloping heart rhythm. There are also abnormal ECG changes. It is important to prevent heart failure in this case. You have to address the circulatory overload. 7. Mild edema or mild anemia may occur because the blood volume here continuously expands. In such a case, children can be given iron. ESR increases. ESR is a sign of inflammation. BUN and CREA in the blood also increases. This shows that the glomeruli cannot filter properly. In the slides, you will see here manifestations or symptoms in bold letters. Those in bold letters are the classical symptoms of acute post-streptococcal glomerulonephritis. Management. Medications such as antibiotics, they are usually ineffective because the disease itself is not caused by an active infection but a previous infection. Furo is of little value also but may be tried in generalized edema because in nephrotic syndrome, the problem is basically the nephrons or the kidneys itself. And we all know that diuretics, such as furosemides, mode or mechanism of action is directed within the nephrons. And if the nephrons are damaged, they may be of little help. Calcium channel blockers may decrease the blood pressure, such as amlodipine, diltiazem, felodipine, difedipine, verapamil. Digitalis may be used if there's already heart failure. The course of acute post-streptococcal glomerulonephritis is about 1 to 2 weeks, and usually it is self-limiting, but then these medications may be of help. Rest and activity. It's important to encourage quiet activities and avoid competitive play. This is to not overstress the kidneys. Make sure that the child can still do simple activities. You do not need to put the child on bed rest. Bed rest is not necessary. Diet. Provide high protein to supplement protein loss, restrict salt to reduce the edema. It's also important to weight the patient every day and calculate intake and output. This is to monitor the nutritional status of the child. Dialysis, specifically peritoneal dialysis, may be required if severe renal problems develop. A few children will not completely recover, but may develop chronic nephritis resulting to renal insufficiency, and this is their last result, which is dialysis. Nephrotic syndrome is an altered glomerular permeability. You may confuse this with glomerulonephritis. Remember that glomerulonephritis is the inflammation of the glomeruli, while nephrosis is the altered glomerular permeability. This is basically due to fusion of the glomeruli membranes, which leads to abnormal loss of protein in urine. The cause is an immunologic mechanism. due to hypersensitivity to an antigen-antibody reaction or an immune process, probably from a T lymphocyte dysfunction. It is more common in boys, mostly 3 years old. They occur in three forms. Congenital, it occurs as an autosomal recessive disorder. Secondary, as a progression of glomerulonephritis, sickle cell anemia, which we have discussed in the blood disorders, and SLE. SLE is also an autoimmune disease where the immune system of the body mistakenly attacks healthy tissues, including skin, joints, kidneys, brain, and other organs. Idiopathic is no known cause. In children, the congenital form is rare, while the idiopathic is the most common cause. Figure 46.12 shows the process that results in the signs and symptoms of nephrotic syndrome. Please remember there are 4 characteristic symptoms, and these are 1. Proteinuria. The increased glomerular permeability leads to protein loss in the urine. Second is hypoalbuminemia. The same increased glomerular permeability subsequently leads to the hypoalbuminemia or a low serum albumin level. Third is generalized edema, to include periorbital edema, ascites, and even scrotal edema in boys. This low level of protein in the blood causes osmotic pressure. Fluid will shift from in to out of the cell. Also, as blood volume decreases, the kidneys begin to conserve sodium and water, adding to the potential edema. Fourth is hyperlipidemia, or the increased blood lipid level. This occurs because the liver increases production of lipoproteins. This is to compensate for protein loss. Lipids are too large to be lost in the urine, so they rise in the blood instead. Figure 46.13 shows a 2-year-old child with the syndrome, and note the extensive edema of the face and the hands. You might be wondering of the similarities and differences of acute post-streptococcal glomerulonephritis with that of nephrotic syndrome. Table 46.5 shows the comparison of their features. In nephrotic syndrome, laboratory studies will reveal marked proteinuria. A single test will show 1 plus to 4 plus protein, while a 24-hour total urine test will show 50 grams protein. Remember a while ago, in acute post-streptococcal glomerulonephritis, the 24-hour total urine test is only 1 gram. So in nephrotic syndrome, it is larger. Again, normally, there should be no protein in the urine. Also, the protein loss in nephrotic syndrome is almost entirely albumin, while in proteinuria of glomerulonephritis, it is non-specific. Some children with nephrotic syndrome also exhibit hematuria at the onset, but it is minimal in contrast to that seen in glomerulonephritis. Hematuria in glomerulonephritis is profuse. Management begins with a course of daily corticosteroids, could be IV methylprednisolone or usually oral prednisone, to reduce proteinuria and subsequently the edema. Corticosteroids are actually anti-inflammatory drugs. It will initially address the immune mechanism causing the altered glomerular permeability. An initial dose of prednisone is given until diuresis without protein loss is accomplished. So every morning, parents must test the urine using a chemical reagent strip and then record. Once a week, it is also important to collect 24-hour urine specimen so total protein loss can be measured too. It should be decreasing because normally, as what I've said a while ago, in a 24-hour urine specimen in nephrotic syndrome, there is about 15 grams of protein, which normally should be none. Second, institute measures to keep the child free of infection while the immune system is suppressed. This is because of prolonged use of corticosteroids. Third, in about 1 to 2 months, sometimes in just 4 weeks, when protein loss is accomplished and edema subsides, prednisone may now be given every other day instead of every day. Why is this so? Prednisone has the potential to halt growth. However, growth is apparently not delayed if the drug is given on an alternate day or on a day after day basis. Fourth, children who respond poorly to prednisone may need diuretic therapy with furosemide or Lasix. You might be wondering also why diuretics are not given for the edema. Again, the problem here is the actual nephron or glomeruli, and diuretics mechanism of action are on the specific structure glomeruli. So their action is not effective because the damage is there. Diuretics are not commonly used here as they tend to cause hypotension and hypokalemia as well. Diuretics decrease blood pressure, and furosemide loses potassium. Hypotension and hypokalemia in this case will further compound the problem. But if necessary, especially with extensive edema or generalized edema, furo may be given, but always check BP and blood potassium. Fifth, IV albumin may be administered to temporarily correct hypoalbuminemia, to temporarily increase albumin and shift fluid into the bloodstream. That's the purpose. It is not recommended to do it on a long-term basis because albumin is lost in the urine. 6. There are no clear guidelines in treating hyperlipidemia, but may try statins, bile acid sequestrants, and nicotinic acid to lower cholesterol. This is important because continuous hyperlipidemia may lead to cardiovascular diseases and thromboembolism. 7. If all else fails, a course of cyclophosphamide, cyclosporine, or mycophenolate mofetil is effective in reducing symptoms or preventing relapses. These drugs are strong immunosuppressant agents, which can again suppress the immune reaction happening in this syndrome. Immunosuppressant drugs are also used as chemotherapy in cancer. 8 are the diet recommendations. Reduce sodium because there is edema. Eat high-protein foods because protein is lost. Avoid fats because there is hyperlipidemia. And monitor fluid intake in order to prevent further fluid retention.